Dr. Stu, I am so excited to have you here today. This is like a dream to have you. And after some technical difficulties, it's also triumphant. So,
Thanks, Jamie. It's well, we just, it seems like we just spoke because we did just speak recently
yeah.
with Blyss on our podcast. So I'm happy to help anybody who's listening to your podcast get new ideas. And I always love being on other podcasts because I get to reach an audience that I wouldn't normally reach. So although our audiences may overlap, but it will be really nice to be able to reach out. As I was telling you earlier, the reason I was a little bit late is because I was talking to a group of birth workers in South Africa. And you think we got problems in the United States?
Yeah.
God, wait to hear about what's going on in
We'll
South
get
Africa.
to that. I would love to introduce you. You sent me a bio. I'm just going to read it because I would add probably way too much. So I'm just going to read your bio. So for anyone who does not know Dr. Stu, what are you doing? But also, I'm sure most of the audience knows who you are, but I'll just read your bio. So Stuart J. Fischbein, MD, is a community-based obstetrician and an associate of the American College of Obstetrics and Gynecology, published author of the book Fearless Pregnancy, Wisdom, and Reassurance from a Doctor, a Midwife, and a Mom, and peer-reviewed papers, Home Birth with an Obstetrician, a series of 135 out-of-hospital births and breech birth at home, outcomes of 60 breech and 109 cephalic planned home birth and birth center births. Also, a twin birth paper is in preprint and hopefully to be published soon, and we'll talk about that. After completing his residency at Cedars-Sinai Medical Center in Los Angeles, Dr. Stu, as he is known, spent 24 years assisting women with hospital birthing and for the next 12 plus years was a home birth obstetrician who works directly with midwives. Since retiring from attending home births in 2022, Dr. Stu has returned his focus to traveling around the world as a lecturer and advocate for reteaching breech and twin birth skills, respect for the normalcy of birth, and honoring informed consent. He hosts a weekly podcast, of course, with co-host Blyss Young, and together they offer hope, reassurance, and safe, honest, evidence-supported choices for those women who understand that pregnancy is a normal bodily function not to be feared. So everyone here should follow Dr. Stu on Instagram at Birthing Instincts if you're not doing that already. And then his websites are www.birthinginstincts.com and also www.birthinginstinctspodcast.com.
Yeah, everything's Birthing Instincts. Yeah. It's actually worked out really well for me. And I picked that name a long time ago, and it turned out to be actually a really great name to have because it is true that that's something that's missing a lot. It's missing in the women of our country. It's also missing in the practitioners of our country. They've lost what birthing instincts are.
So how did you come up with that name? Was that I know that's the whole premise for it, but what made you choose that name specifically?
I don't know. I don't remember any specific event that made me think of that. You have to think of names when you're creating it was initially a corp. I was incorporated in California for a long time, and just recently when I moved, I dissolved the corp because I don't need it anymore, and I got tired of paying California $800 a year for nothing. So, but I think you just had to come up with a name, and that popped into my head, and it was a while ago, so it was fortuitous, and it's great because now that everything that I do is listed under, so people just have to like Google birthing instincts and that will come up. So
awesome.
Right. But I think it had to do with mammalian birth and the fact that we've lost it. One of the very first lectures I ever did, Jamie, was titled Home Birth is Not Just for Hippies, What Mammals Know and We've Forgotten. And I think that it, probably stemmed from that.
I love it so much. I love that. Okay. So you are making such a huge impact in the birth world, like so many ripples, and we'll talk about a lot of those different things. And of course, we met, just to go back a little bit. So you and I met in person at the Born Free Twins and Breech conference in Kentucky in August. So just to give listeners a little bit of context around that, I mean, I've been listening to your podcast for years and years and years as a doula, as a mom. I mean, I was just telling the producer here that Baxter that we at this audience, we binge like we binge birth podcasts and get all the information that we can. And your podcast is one of those that is really incredible to just listen to it and to binge with you and Blyss. So I want to thank you for that contribution because it's not an easy thing to do every single week. I'm only a couple episodes in, and I'm really grateful that you're taking the time out to spend with me today, in addition to everything else you're doing.
Well, the evolution of the podcast has been fun for me to look back at. It started because I was having breakfast with a friend of mine who was a radio DJ in LA at the time, and his name was Brian Whitman. Is Brian Whitman? I just haven't spoken to him in a while, but we were having breakfast, and he asked me a question, and I went on a rant, and he just said, "Stu, we got to do a podcast." And this was in 2013, and I think it was 2013, and podcasts were just in the infancy in that point, so I didn't really even know what a podcast was. And then if people go back and listen to the initial ones, the format was completely differently. It was essentially Brian was interviewing me and asking me like dumb layman questions and dumb guy questions, and we had a studio where we had a producer who had a sound effect machine, and we had little sound effects, and it was very professionally done at the beginning, and we actually copyright infringed music from Thor and then eventually from Interstellar. I didn't realize that you can't do that. So the first episodes, and then first episodes were only like 30 minutes long, 35 minutes long, because Brian said that people don't have an attention span longer than that. And then, I think Joe Rogan proved him wrong because his podcasts are 3 hours long and he's got the most popular podcast in the country, I think. And so ours have gradually gotten longer and longer. And then, I went through different hosts, and finally Blyss and I have been together since 2017. And yeah, it is interesting. I mean, we never seem to run out of topics. And sometimes we have guests a lot lately. And I miss the fact that when Blyss and I just used to talk because I get so much that comes across my desk every week. And it used to be that my own clinical experiences when I was practicing, and I would share those stories and things like that. But it got to the point where, I would just sometimes prefer to just have a chat with Blyss for an hour and a half. But she likes having guests, so she wins.
All right. So, of course, we're going to dive into birth and so many different directions that we could go. And you are such a wealth of knowledge. I want to start by knowing a little bit more about you as a person. So I know you grew up in Minnesota. I'm interested in knowing how you started in medicine in the first place. Like, what drew you to medicine?
It's not what people would think. I didn't have an inspiration to go into medicine. I don't mean this to be sort of funny or cynical at all, but I was the son of a Jewish mother, so I didn't have a lot of choices in life. If people will understand what I mean by that, I mean every Jewish mother wants their son to be a doctor or a lawyer or something like that. And so I graduated high school and I went to college like everyone else did, just automatically. I think that's still pretty much the way it works. And I was meandering through college. I was a science major because I was a biology major because I really like sciences, and I thought I wanted to be a marine biologist or work for the Forest Service or something like that. Be outdoors. I really liked being outdoors as a young kid, and I did a lot of outdoor stuff. And Minnesota was a great outdoor state. People don't understand that because it's so cold in the winter, but it's a great outdoor state. We've got a lot of recreation and stuff outside, and that's what I wanted to do. And about two years into my undergrad, I had already taken organic chemistry and calculus and physics, and because and they were all prerequisites for medical school. And some of my buddies were going to they were going pre-med, and I just decided that I would do that too. And it was a whole different world back then. We're talking about the late 70s. And so I took all the courses that I needed to take, and then took what's called the MCAT, which is test you take to get a score, and then you apply to medical schools and you go around and interview. And I got into a couple others, but Minnesota was really inexpensive. People won't believe this, but I paid $700 a quarter
Holy cow.
at the University of Minnesota from a med school education. It was state funded, but still, I mean, that's a ridiculously low number. Even in inflation adjusted dollars, it's really still a ridiculously low number. And so I got a good education at the University of Minnesota. And the first 2 years, of course, are almost all classroom. And there's some laboratory, and then there's anatomy lab. And then the second 2 years are generally rotations. You do some core rotations that you have to do, like internal medicine, OBGYN, pediatrics, surgery. And then you had electives like ear, nose, and throat, radiology, dermatology. And I had just come off a hematology oncology rotation, which I quite frankly found quite depressing. And my next rotation was just one of those serendipitous things in life where it was OB. And I saw myself up at 3 a.m. catching a baby rather than pushing chemotherapy or dealing with some fungal infection in some kid's brain and seizures and that sort of thing. And I just sort of liked that. Then I began to think about, well, what is it about OB that I really like so much besides catching babies? And there was, because it's one of the only three specialties that has what I really wanted in medicine, which was longitudinal care, which is taking care of people over time. So getting to know them as opposed to being sort of a cute saying, but a whack-a-mole physician where, you come in with a ruptured appendix and I take care of your appendix, or you come to the ER with a laceration in your leg and I sew that up, and then I never see you again. So internal medicine, family practice, and OBGYN are the three specialties that take care of people over time. And OBGYN offered a few other things that the other two didn't. One of them is surgery, which I really liked. I don't miss it now that I don't do it, but I really liked it at the time. Little endocrinology, a little psychiatry, a little internal medicine. You got to do it. Plus, you got to catch babies. So it made an easy choice for me. And then, so again, I didn't get into medicine because I had a yearning for being in medicine, but I did pick OB because I did feel like that was a calling for me. And then you have to make a decision in the end of your third, early fourth year of medical school when you're totally unprepared for this decision because you are naive, you're idealistic, but you don't know anything. And you have to apply to residency programs in that specialty that you think you might want to do. And it's going to really guide you for the rest of your life. You're sort of committing yourself down a path before you're absolutely ready. It's like a shotgun wedding, I suppose, where you have to make that decision. And so I applied to residency programs in OBGYN. And then one of the true sliding door moments in my life was that third Wednesday in March of my fourth year of medical school, where you get an envelope. It's called the match. And in that envelope tells you where you're going to be doing your training. And I matched at Cedars-Sinai Medical Center in Los Angeles. And had I matched at the University of Colorado, which was my first choice, or University of Iowa, which was my second choice, my life would have been completely different. But I matched in Southern California, and Southern California in the early 80s was a dream place. Smog was bad. The only thing that's gotten better in all the 40 years that I lived in California was the smog. They did take care of that, but everything else got worse. But it was a dream place to live, and I got enticed by it. I got a great job offer when I finished my residency, and I got very well trained at Cedars because Cedars had an affiliation with the busiest hospital in the country at that time, which was LA County USC Women's Hospital. And so I got trained in breech and twin delivery as just essentially normal. Actually, we liked doing them. They were fun to do. And because it was still considered just a variation of normal, it was normal. And I don't think I would have gone to a different program. I would have had that sort of training, and I might not have ended up, reteaching breech and doing the things that I'm doing if I hadn't opened that envelope on that particular day and found that I was going to end up in Southern California. So that's sort of how I got into OB. But I didn't come out, obviously, in 1986 from my residency the same person I am in 2024. Not even close.
So one of the burning questions that I have about that is that Right. So you go in, you get all these trainings, which were not, I mean, they were common back then, it sounds like, or at least for that hospital. And so you just did a podcast about, or not just, but you recently did a podcast about the vaginal triplet birth that you did with Laureen, and you supported her in the hospital, and you said that you got a lot of flack for that. So how did that work? Like, did things change as time went on from when you got that breech and twins training in residency? Was it just because it was triplets, or what was the sort of the dynamic there?
Oh, well, the triplet thing was, the reason I was able to do triplets partly is because I was a solo practitioner. So I didn't have a boss. The hospital, you have to have privileges at the hospital. You have to, have them renewed every 2 years, that sort of thing. So, but I didn't have anybody telling me that, no,
Got
you
it.
can't do that.
So it was just colleagues
Right.
sort of looking
So,
over their shoulder, like, what's this guy doing?
but it made everybody at the hospital nervous because nobody did that kind of thing. So why did I do it? I think I did it because over the years, I began to see another way. First of all, I was well trained, and I thank my training program, and I thank LA County USC, and I thank all the women who had no idea that we were training on them. They were is essentially a mostly illegal immigration Spanish population, and obviously we did things there that were probably not in the most ethical sense. I mean, the anesthesiology residents put epidurals in women who didn't need an epidural. They did it for practice, and we put forceps on babies who didn't need that. But that's how you're going to get the training if you don't do that. And so, in those days you got away with it at county because they were doing 65 babies a day and 22,000 births a year there. And so, we got away with it. And, it's good training. Now doctors, unfortunately, are de-skilled. They don't have that training. But getting back to the point was that um, because I was skilled and because I had started working with midwives and I'd realized that much of what I had learned about medicine and obstetrics was wrong, not just different, was wrong. Um, and then, Laureen, if you listen to the podcast, I think she fully expected to have a C-section. I think I offered it to her that when you want to deliver them vaginally, and she said, okay. But yeah, why not? We're in the hospital. We're in one of the best hospitals in the country, actually. And if things don't go right, I mean, we were delivering in an operating room because they still do that at Cedars. If you have twins or triplets or anything, you can't deliver in a labor room. You have to be in the operating room, as if that makes any difference. But that's a whole other topic. Maybe you'll even go there. I don't know. So that's what happened, and yeah, and it was a beautiful birth, and I even let the chief resident do the third baby was a breech extraction, and I let him do it,
Mhm.
and I'm sure to this day he remembers doing it. Right? I don't know that he's still doing them, but I heard that he was a good, he was practicing in the other part of Southern California for years, and I heard that he was very well liked and good at what he did. So I'd like to think that part of that was because he got the same experience that I got um, in training, which is now not available to 99% of OBGYN residents anymore. And even if they could do it, when they come out, they're told they can't do it by their overlords.
Yes. So okay,
That was a
this
big
is kind of
sigh.
jumping around, but I'm gonna just go there anyway since you brought it up. So I put out a question to my Instagram, just saying, what questions do you have for Dr. Stu? Because this is like a huge opportunity for some of these people who, would never get to talk to you in person. And one of them, I have a lot of midwives there on my Instagram, and one of them is just like, she's asking, how do we troubleshoot this? How do we, it's such a hierarchical thing. And to your point, these overlords, they won't allow these things to happen. So like, how do we go about trying to solve that? And I know that you and I are not going to solve this issue on this one podcast episode, and what you're doing with your reteach breech workshops is is, you're making a huge impact with that. What else can you say about, like, what else can we do, either as doulas, as midwives, as birth workers, as parents, to shift things?
Well, I think it's interesting. I just got off this Zoom meeting with our South African birth workers just now, and we talked about this topic because it comes up a lot. And I think you always fear what you don't understand. And the truth is that most women don't understand childbirth. I mean, they have all the parts, but they don't understand it because they're not taught anything about it other than what they are seeing on TV or what their ancestors tell them. And often it's scary stories. And so they begin to fear birth. And once you plant seeds of fear in there, you can manipulate people to do anything you want. So what we need to do is bring back the normalcy of birth. I'm really thinking that where that needs to start is like in high school. And we need to, I'm not talking about teaching medical students and midwives and stuff. We need to teach the women how normal childbirth can be. And we need to teach the men, the boys in high school, how it works so that there's a general understanding so that over a generation or two, we can then change the flow of the argument away from fear more toward the normalcy of mammalian birth. So one of the things again, this isn't going to happen for you or me overnight. It's not going to happen. The powers that be are too happy with the way the system is right now. It's making somebody a lot of money, and so you can't suddenly get that to change. Hospital systems won't change. I've watched the hospital systems over the 40 years that I've been around, and it's only gotten worse.
Mm-hmm.
They know certain things they're doing are wrong, and they do them anyway, and they double down on doing more of them. It's classically the definition of insanity.
Yeah.
Yeah, our outcomes are bad. Let's do more of what we're doing because we'll get better outcomes. It's like, no, that's not how it works. So one thing is to educate the population and return the normalcy of childbirth, and that's why documentaries about childbirth, like there's several that have just come out the last few years, which are really good. These things need to be shown in high school, and they need to have people going around, midwives going around to high schools and showing them, you know, about teaching them about the normalcy of birth, showing them what they bring to a birth, bringing their birth kit and opening it up, laying it out on a table, and showing them so that they understand that, and then talking about mammalian birth, that sort of thing. So that's one thing that we really could do, and that wouldn't be hard to do. To try to, well, it would be hard to do because academics don't listen to reason anymore. They don't teach normal stuff anymore. They don't teach civics and physics and stuff in school anymore. They teach stuff that really isn't practical in real life.
So if I can cut
But
in
they have
for
an
a
agenda.
second, if anybody who's listening does that or knows somebody who does that, can you reach out to me um, on Instagram? It'll be at triumphant_birth. And I would love to connect with you because this is how we change it. It's sort of like life by a thousand cuts, I feel like, instead of death by a thousand cuts. So continue.
I would love the opportunity to go and speak to high school students, even though it's maybe 30 at a time, but I don't care. I mean, I teach seminars of 15 to 25 women at a time, and they go out, and then their ripple effects just spread out. And I hear every week, not every day, but every week I get a story from somebody who took my class or the Breech Without Borders training, and they had a surprise breech, and everything went beautifully because they knew exactly what to do or what not
Yeah.
to do.
Right.
Actually, you know, it's so much about and many times it's so much about knowing what's physiologically normal and what's not, and if things are going normally, then to just let it happen. Um, so that's one thing. Another thing too is getting to medical students and residents, especially residents probably, um, and reteaching the skills that make the profession of obstetrics a profession. I don't really think I know that this sounds controversial, but I've said it many times, so it doesn't sound controversial to me anymore. But I mean, what makes obstetricians unique from any other specialty? I mean, catching normal babies, midwives can do that. Family practice doctors can do that. Taxi drivers can do that. theoretically.
Moms
I
can
mean, they
do
do it.
that.
You hear it all. Well, it's not so much taxi drivers, but everybody knows what I mean by that. Um, is it gynecologic surgery? Well, GYN oncologists can do that. General surgeons could do that. Um, is it reproductive endocrinology? Well, they have specialists and there's subspecialists in GYN oncology and reproductive endocrinology and maternal fetal medicine and GYN urology. So the generalist OBGYN really has no function anymore. They're essentially a high-priced generalist. And what's going to happen is these managed care companies are going to figure that out. And they're going to say, why am I paying $200,000 a year to have an OB when I could pay $95,000 a year and have a midwife? And then just have a general surgeon or a MFM on staff who can do the C-sections when necessary. Why would I do that? Because the one skill that makes our, well, there's more than one, but the skills that make the profession unique are the things that aren't being taught anymore, like forceps delivery, like breech delivery, like breech extraction of a second twin. Simple, simple skills that 50 years ago were the norm when the C-section rate was 5%. And the outcomes from those births were better, or certainly not worse than they are now. And they're likely better. I mean, maternal mortality is rising. Infant mortality has not changed, despite the fact we've had a 600% increase in the cesarean section rate. So what's the point of all this interventional birth? And what's the downstream consequence of this? What are we doing to ourselves as a species when we're altering the nature's design that was designed over eons? Sarah Buckley likes to say it's been 64 million years. You know, whether it's been a few 100,000 or 64 million, what are we doing when we're suddenly thinking that, you know, we have the hubris to believe that what we're doing is going to be better than what nature has designed? And there's this basic tenet in medical ethics, two of them. One is called the precautionary principle, which means you don't experiment on pregnant women and lactating women. And the other is the idea that if you're going to intervene upon nature's design, you have to prove that your intervention is safe. And I hate to use the word effective, but is safe before you intervene. You have to assume that Mother Nature's design is the safest design. And yes, can things go wrong? Of course they can. But when left to its own accord, nature has designed this model for a reason. And it's only when we meddle with it, maybe it could be something as simple as the food we eat that changes, you know, our, you know, babies' weights and our, and that sort of thing. Those are artificial things, but we're talking about, you know, we have 30-40% induction rates of labor now. You know, how many deer need to be induced? We have C-section rates of 30 to 80%, depending on what country you're in. What's the C-section rate in anything but a French bulldog? I mean, you know, there was a story recently about a gorilla that had a C-section for preeclampsia. Right? Now, it's fascinating to me, like, how did they know the gorilla had
Right.
preeclampsia? This is like, what, are they taking the gorilla's blood pressure now? You know, I mean, and so the C-section makes the news. When 9 million previous gorillas were born vaginally, doesn't make the news, but a C-section. And so now the next zoo is going to want to outdo that zoo, and they're going to be doing a C-section on the next gorilla, and then the gorilla will not bond with its baby. We're altered nature's design. Did we do that gorilla a favor? Who knows? But we can't stop meddling. It's the nature of medicine these days. It's counterintuitive. Medicine should be about making people better and well, and it isn't actually anymore. Because look at the results. Look at our outcomes. Got a generation of children sicker than ever before. We have higher C-section rates than ever before. We have higher postpartum depression than ever before. We just did a thing on tongue ties, a podcast on tongue ties. It's like, wait a minute. Like, was tongue tie a thing 50 years ago? No. Was Sid's death a thing 50 years ago? No. These are man-made diseases. So we need to really think about what we're doing before we interfere with Mother Nature's design, and yet we don't. And maybe it gets down to the simplest thing, Jamie, and that is there's no money in not doing something.
Right.
I jokingly say that, if we paid people for not giving hepatitis vaccine to a newborn, then the newborn babies wouldn't get hepatitis vaccine. But because they don't pay for not giving hepatitis vaccine, they give hepatitis vaccine because it is the dumbest vaccine of all time
Hmm.
to give all newborn babies hepatitis vaccine. Because hepatitis is a sexually transmitted disease or a disease of IV drug abusers. And the parents don't have it, then the baby can't have it.
Yeah.
But we're going to give the baby 250 micrograms of aluminum uh, when it's 1 hour old and a shot in the thigh with a bunch of other stuff that are chemicals for a baby that doesn't need that. Because nature's design is obviously not perfect. We have to protect that baby from a disease it can't possibly
Yeah.
get
So
because we can
I'd love
charge
to
for
do
it.
an episode on either with you or someone else on all of the newborn procedures and like going through all of that and the sense that that makes or doesn't make. What you're describing, what you're describing overall is the core difference between the medical model of care and the midwifery model of care. So
Yeah.
how I'm curious how that transition happened for you because you, for anybody who doesn't know, you left the hospital system, and I've heard it before, but for anybody, any of our listeners who has not heard the story of how you left the medical model and started to become familiar with the true midwifery model of care, because we all know that there are some OBs who practice the midwifery model of care, and there are some midwives who practice the medical model of care. It's not like a clean thing. Um,
And it isn't
right.
cut and dry. There isn't just one medical model of care and there isn't just one midwifery model of care. You're
Yeah.
right.
So
So,
how
oh,
can
go
you,
ahead.
so how, what did that look like for you? Because I know that you started supporting home birth midwives at some point, and maybe you weren't necessarily like bought into the midwifery model of care, or were you at that point? How did that all look?
No, no. I mean, again, it gets back to my origin story where when I finished my residency, medicine was different than it is now. Now, most doctors come out, they get hired by a company. They get paid a salary, they work a shift. It's a much better lifestyle, but it's not better for the women that we're caring for. And I'm not sure that it's as satisfying as the old fashioned style, but it is a better lifestyle because you're not on call 24/7. But when I came out, you didn't do that. You built your practice from scratch. And so when young doctors came out, what they did is they covered other doctors when they were on vacation. They assisted them in surgery. They covered ERs. They worked at free clinics. And one of the things that happened to me early on was I was approached by some home birth midwives in LA and asked if I would take their home birth transports. And I've said this 1,000 times, but I said sure, because every time they would transport somebody to me, I could bill for that, and that was revenue for me. And I got paid pretty well. I got paid $2,000-3,000 for that in those days. That was pretty good money. But I didn't do it because I thought home birth was a good idea. I'm pretty sure that I thought it was a stupid idea. Because I was trained in a residency program where we often would see only the train wrecks from hospital and home birth. And so I didn't know anything about midwifery. I mean, there were some midwives that worked at LA County USC, but they were up on the 8th floor and we were on 5. And so we rarely ever encountered them. So I really had no idea about what they did or the difference between the two models. That was not taught to me. But that was fortuitous that I took them, because when their transports would come in, I would realize that they're not sick. These women, they're just exhausted or they need an epidural. 9 times out of 10, they were not emergencies. I mean, more than that, 99 out of 100. Um, and they just needed an epidural and some PIT, and they would generally go on and deliver vaginally. And occasionally they wouldn't, and they need a C-section. But during that time, I would end up spending time. I would go to the hospital because it wasn't that busy, and I'd meet them when they came in because I knew I wanted to treat them humanly, like they're coming in against. This is not their birth plan. They don't want to be there, and they're coming to a hospital where they don't know anybody, and their midwife is coming with them. And so I would meet them there, and I would sit in there and I would chat with them for a while, and we'd get them comfortable with an epidural, whatever they needed, and then we'd talk a little bit more, and then I'd let them rest for a while, and I'd go in the lounge, and the midwife would hang out with me, and we'd start to talk, and I would just begin to hear different things, way of doing things, and it just made a lot of sense to me over time. But it took about 10 years before I felt really comfortable. And then I was encouraged by a friend of mine to start a collaborative midwifery practice with 2 certified nurse midwives at a hospital in Ventura County, which was just north of LA, because Cedars-Sinai did not allow midwives to have privileges at that time. And I was not ready to do home birthing. It was just a hospital-based practice. And we had a really good thing going because the midwives took care of all the normal stuff and I took care of the complicated stuff. And that really was the way it should be. They were trained in, they're experts in normal and I'm experts in complications. And so it really worked well. And we had a 15-year run at that hospital where we had a C-section rate of 7%. And we took all comers. So we took, breeches and twins and preeclamptics and preterm labors and normal, everything normal. And we did normal gynecology and all that stuff. And the midwives would do the normal stuff and I would do the things that were problems. And after, all the years we were there, we were never accepted in that community. We were always picked on because we made them uncomfortable because we were different. And when you're different, even if your standard is better, you're considered outside the standard of care because the standard of care is what other members of the community would do. And if the community is way behind the times, like I was the first person in that community to do laparoscopic surgery. So if a woman had an ectopic pregnancy, I would do it laparoscopically. They would do it open, laparotomy. So I was actually outside the standard of care in that community, yet I was the one doing the higher standard of care. It's baffling when you think about the wording of how that works. So we made the nurses nervous. We made the anesthesiologists nervous. We made the pediatricians aggravated because our clients didn't want vitamin K. They didn't want hepatitis vaccine. They wanted to go home 6 hours after they gave birth, and that it could have been in the middle of the evening or night. And the pediatricians didn't want to come in, and so over time they made it more difficult for us. And just shorten the story, they banned vaginal birth after cesarean, and then they banned the midwives from the hospital that was right by our office, and then they banned breech delivery. And they threatened me and they said, if you do more breech deliveries, we're going to suspend your privileges. And I said, well, you can't, because I have a sheet here signed by you called a privileging sheet that says I can do breech delivery. And ultimately the story was, well, you're up for reappointment this fall and when we're just not going to reappoint you. And they have the right to do that. And I have the right to fight them legally, but that's usually a losing battle. So, and all you would win is the right to stay at a hospital that doesn't want you there anyway. So it was never about the care that the women were getting, clearly, because we took our 7% C-section rate and our higher satisfaction rate, and they kicked us out of the hospital. And they were happy with what they were doing because obviously a higher C-section rate generates more revenue for the hospital. And maybe that's not it. And I was probably difficult to deal with because I was obstinate that had a better way of practicing, and they're all fools. And I know that sounds harsh, but that's actually the truth. And so I was encouraged by my midwife colleagues and some of my clients who were due after my end of my term was to go start doing home birthing. And I was actually 25 years into practicing at that point, and I'd yet to be at a home birth. So I was backing midwives for almost 25 years, and I'd never gone to a home birth, which is a problem with the medical model because there's no mixing of the silos. Doctors they hate home birth because they don't know anything about it. They fear it because they don't know anything about it. But so I did. And fortunately, the first bunch of women that I was fortunate enough to take care of all had beautiful home births. And then eventually I got braver. And I said, well, if I could do breeches at hospital, why can't I do them at home? And twins. And then I think I started taking on type 1 diabetics, hypertensives when they're well controlled. Why should they be denied the type of birth simply because they have a diagnosis that really doesn't affect their labor? And if it affects their labor, then they can be transferred into the hospital at that time. But it never affects their labor in the way that the emergency environment of the hospital tends to think that it's going to be like suddenly something's going to go wrong. And one of the things about home birth that you understand is when you don't meddle with nature's design, you rarely see the sudden deterioration of fetal status. I know that, your story was a little different, and that's not in twins these things can happen sometimes, but you rarely, and they can be dealt with at home too, but you rarely see that unhappy fetal heart rate trace. First of all, we're not doing tracings, and we're not doing continuous monitoring because the data doesn't support it. But you rarely see that sudden deterioration of fetal status. That means you have to do a crash C-section. That was all caused by the model by which you were being cared for in the hospital, because we're not doing that at
So
home.
can we talk about for a second? So just to like back up a little bit. So it really sounds like, I mean, at the end of the day, the hospital saw you as a liability and the midwives saw you as an asset, which you are.
Yeah, I guess that's a good way of putting it. I don't know that the hospital actually believed that I was a liability, but I was causing unrest in their other
Yeah.
departments. And the anesthesia department and pediatric department are more powerful. First of all, the OB department wasn't going to come to my defense anyway. I told you they weren't happy with me because I was doing things differently. Uh, and I wasn't, I wasn't, again, you could say I wasn't a team player, but the truth is I didn't want to be on their
Yeah.
team.
Because they didn't have the well-being of the moms and the babies were not front and center. Yeah. I think this is a beautiful segue into a conversation about risk. So I know when you gave your talk in Kentucky, you had talked about, and you talk about this elsewhere too, but um, so high risk versus low risk. Where is the line? Who defines it? What do you think about that? Because now you're exploring, you're out there in the home birthing community and you're exploring, okay, well, why can't I do a breech delivery? Why can't I do a twin delivery? Why can't I do someone with maybe a little bit high blood pressure but isn't preeclamptic yet? Um, how how did that look for you? And like how do you define high risk and low risk?
Well, I have an analytical
Hmm.
brain and I'm a very common sense thinker. And high risk has no
Yeah.
definition. You can look it up and it doesn't have a definition. And so ultimately I'll get to this, but high risk is something that makes the practitioner uncomfortable. That's what high risk is. So, for instance, VBAC is considered high risk. But the risk of having the scar of your uterus separate after one low transverse cesarean section is about 1 in 200. The numbers are between 1 in 200 and 1 in 333, depending on which paper. But let's just take 1 in 200. And the risk of having an adverse event from that scar separating is somewhere between 5 and 16% of those babies will suffer a very serious injury or death, which is obviously horrible. But let's take 16% because it's higher. So 16% is about 1 in 6. So the actual risk of any woman having a VBAC after one low transverse cesarean section is 1 in 6 times 1 in 200 or 1 in 1200 of having a bad outcome. That's how the statistics work. So they're going to tell you that 1 in 1200 is high risk. All right. But that's lower risk than a 25-year-old having a Down syndrome baby. But they'll never tell a 25-year-old she's high risk for having Down syndrome. So the number doesn't mean anything. And for instance, which is riskier? A woman over age 35 or having an induction of labor? One is labeled
Yeah.
high risk. The other is labeled normal and a remedy for high risk. But the induction of labor carries far greater risk than just because a woman's over 35. It's an arbitrary, ridiculous, stupid number in the first place. And I got a whole talk about age 35, but you asked me about high risk. So ultimately, high risk is something that the doctor or the hospital system doesn't like. So in other words, like let's take breech birth, for example. The best numbers on the risks of breech birth come out of the Royal College of OBGYN's Green Top guidelines. And they say that the risk of a neonatal death, which is again, if you look at any endpoint in any paper or any textbook or any guideline put out by the American College or the Royal College, they're always looking at neonatal death and neonatal morbidity as the only endpoints that matter. But there's a lot of other endpoints that matter. Obviously, that's important, but How's the baby doing 2 years later? How's the mother? How's the mother's psyche? How's the mother's future pregnancies? How's the mother's breastfeeding? How is bonding? How, those things are never considered in a paper. So the Green Top guidelines describe the risk of a neonatal death from a breech birth vaginally at term as being about 1 in 500. So that's a 99.8% chance that it will not happen. The risk from a head down vaginal delivery is about 1 in 1,000 for a neonatal death. So that's about a 99.9% chance of it not happening. So what they would have you believe is that we need to section all breeches because breech is high risk to save one baby out of 1,000 without any concern about what that cesarean section is doing to those 1,000 women and that baby and that mother's recovery and that mother's long-term health and that mother's future babies and the risk of uterine rupture and the risk of abnormally invasive placenta and the risk that she may want a second and a third and a fourth baby. And is she now going to have to deal with the VBAC issue, or is she going to have 2 C-sections, 3 C-sections, 4 C-sections? Who knows? All right. None of that's considered because, as I famously am quoted for now, all that matters is a live baby in the bassinet to the medical model. So which is breech birth really high risk? Or is it something that makes them uncomfortable, therefore they label it high risk? Is 1 in 500 high risk? Because the risk from a cesarean section causing a complication is far greater than that. Whether it be, adhesions or scar tissue or injury to internal structures or problems in the future, your risk is higher if you want more children. And one thing the medical model rarely does is when they tell a woman who's having her first baby that she has a breech and she needs a C-section, they never ask the question, almost never. I've never seen somebody ask this question about, do you want more children? Because if you want more children and you're doing a C-section for that breech baby, then you've done nothing. Because now you've put all her future children at greater risk. But you don't consider that because it's not part of your equation. So again, high risk is not a number, and higher chance does not mean high risk. High risk is something that makes the practitioner uncomfortable. And that's how we should be defining it. And if your doctor is uncomfortable with you going past 40 weeks or 41 weeks, or you being over 35, or your baby might be too big, or your baby might be too small, or your fluid might be too high, or your fluid might be too low, or you have a breech baby, or you're over 35, or whatever reason, that's because they're nervous about it. They've been taught to be nervous, or maybe they've had a bad experience in life and they've got a little PTSD. Who knows? But it doesn't make it high risk overall. And ultimately, the decision of how to proceed in any pregnancy belongs to the pregnant woman, because no two people are going to assess risk exactly the same. As a matter of fact, it's a basic tenet of medical ethics, Jamie, that given the same information, it's not reasonable to expect two people to come to the same conclusion. And yet the hospital model wants every woman to be funneled or coerced, whether subtle or overt, into a decision that the hospital wants them to make. And so they'll be given information which is skewed to funnel them down that path. And this is a violation of every tenet of medical ethics, but it's expedient. It makes more money. They feel it's medical legally more sound. So again, all these decisions are being made not for the woman and her baby, but for the system or the practitioner, to benefit them and not her. Sometimes the two cross, like a broken clock. Sometimes the recommendations are wise, but most of the time they're not. And this is something that it took me a long time to learn. And I think if people would stop and take a look at what they're doing and just, again, as I said, look at outcomes and see where we're at right now compared to where we were at 50 years ago, they would find that, we're not doing it right. You would never run a company where it's the definition of insanity, where you're doing something and you have bad outcomes and you say, okay, let's just do more of it. That makes no sense whatsoever.
And
And then you look at the
Go
disingenuous,
ahead.
one more thing. And then
You're
you,
good.
sorry,
You're
I'm
good.
just monologuing, but this is what happens to me. One more thing. The disingenuousness of when you see people who are defending that model compare birth to how it was 100 years ago. Because 100 years ago, we didn't have surgical sterile technique, we didn't have antibiotics, we didn't have a lot of things. But compare it to 50 years ago, 1970, 74, right, where the C-section rate was 5.5%. And the outcomes were at least as good, if not better, than they are now. And we didn't have all the chronic problems we have now in mothers and babies. And right, so that's a false argument that they make. And one other thing you said at the very my introduction, you said something about I said honest evidence-based information, and I say that particularly because doctors will always say that they're doing evidence-based stuff. It's evidence-based. Well, that's bullshit, because evidence is only as good as the evidence-based medicine is only as good as the evidence that's put into it. And if you're putting in crappy evidence, then your evidence-based medicine's got to be crappy. So that's why I put the adjective honest in front of evidence, because it's a lot. There's a lot of dishonesty out there.
Yeah. So I have this whole page full of questions, and you just covered probably 3/4 of it, which is amazing. Um, it just highlights to me, like there's so many directions we could go, but it highlights to me what value the midwifery model of care has. Like one of the biggest values of midwifery is the capacity to individualize care, and that's what makes it safer. One of the things. Um, okay, so where do we want to go next? So if listeners are going back and forth between what they want to do, like maybe they don't feel um, super confident in a home birth or a birth center birth, anything that's out of the hospital, um, but they still want to avoid that fear and that like blanket level care. What's one thing that they can do, or what sort of advice can you give to them on how to navigate that decision? Because it's a huge decision. It's a life decision. I know we do the wedding analogy a lot. It's a big life event. So what advice would you give them?
Well, in an ideal world, people would check these things out before they're pregnant. For one, they would check out their community. Wouldn't just go to somebody because they've been doing their Pap smear for 10 years, and say suddenly now you're going to catch my baby. They wouldn't do that. They investigate things. So one of the things I tell when I speak, I tell whoever's listening that they should go and interview when they move to a new community, or if they're living in the same community. One of the things you check out when you move to a new community is see, where's the schools, how far am I away from the, where's the Costco, what's the real estate values, what's the neighborhood like. You check things out. So check out the hospital. Go to the hospital in your community. Even now, even if you live in the same community and you're not, go to the hospital, go to labor and delivery, and just ask to speak to one of the nurses there, and ask questions, like simple questions like, I mean, what's your induction rate here? Who are the best doctors in your community? If I'm in labor, does my doctor catch my baby, or is it just random? Did you have a shift thing going on here? What do you feel about going past 41 weeks? It's the same questions you'd ask. I put together a whole list, and I'm going to put it up on Patreon, on our Patreon segment, um, section, on questions to ask when you go for that first interview with your doctor. And so check out the hospital, and then interview your doctor. If you get pregnant, or even before you're pregnant, make an appointment, pay for an appointment, and go in and say, listen, I wanted to talk to you about, I'm thinking about getting pregnant and I have some questions, and see how they look at you. Do they make eye contact with you? Do they give you the time of day? Do they feel rushed? Because as you said, midwives will never get rich because they have individualized care, which means that the prenatal visits are generally almost an hour long. And you can't make a living as a physician doing that because your overhead is so high. The system has totally screwed the average physician out of being able to do an individualized care practice, so they have to do volume. And when you do volume, you can't possibly give the same sort of care. So are they giving you the time of day? Are they making eye contact with you? How do they answer these simple questions? Do they seem to be sincere and honest, or are they rolling their eyes and getting huffy? Find out, size them up, because it's one of the most important decisions you can make is to have somebody on your team, because mammals labor best when they feel safe and they're in a trusted environment. And one of the big questions to ask the doctor is like, if I come to you, what's the chance that you will be the one on call that night when I'm in labor? And you might find that it's 1 in 7, and that's not very reassuring. That's not a continuity of care model. And even if it's 1 in 7, if you're in labor and that doctor's on and you go past 7 in the morning, they change shift. That doctor goes off and another doctor comes on. So that's the way medicine is right now. It's not geared toward individualized mammalian physiologic birthing. So one of the things, so educate yourself, um, and then hire a doula, 100%. And if you want to have a hospital birth and you can afford it, again, a lot of these things are money based and some people can't afford it. And I totally get that. That's not really fair. I don't know what the answer to the non-equity is in birth, but obviously there's systemic problems in our birth system. I mean, Black women and people of color are far more likely to have C-sections and have complications than affluent white women are. But if you can afford it, definitely hire a doula. And theoretically, even if you feel safer having a hospital birth, consider hiring a midwife to do some of your prenatal visits. And maybe even we're acting as what's called a monitrice, which is where somebody comes to your house in labor who's medically qualified. A doula, even though they probably are medically qualified, aren't legally able to, like, take your blood pressure or listen to the baby heart rate. You could listen to your own baby's heart rate. You could be taught to do that, but you won't know how to interpret that. And the doula is not supposed to
Right.
interpret that, although they can. Um, but so they can keep you at home. The monitrice can keep you at home until you're like ready to push. Because the problem is that most people go to the hospital way too early, and the hospital isn't a babysitting scenario. You're there early. You're not doing anything. They either want to send you out, which is fine, which you should, or they're going to meddle with you. They're going to say you're here anyway. They're going to do an unnecessary vaginal exam. They're going to find your 4 centimeters. They're going to say you've got a bulging bag of waters. Let's just break your water. And then your labor peters out because you're scared. And then they say, let's start Pitocin. And then the Pitocin is too strong. And so you want an epidural. And now you're immobilized and you're numb and you get hyperstimulated with epidural and your baby doesn't like it. And that whole cascade of interventions occurs because you went to the hospital too early. And the hospital doesn't know how to not do something. They don't. And it's not, again, it's not the individual nurses or doctor's fault. It's the whole system is geared toward the more they do and the faster they do it, the more revenue comes in and the more they can turn over the beds and they can get that live baby in a bassinet and move on to the next task. And it's not about individualization because they don't know you. They may be the nicest person in the world. They may want to do the best job they can possibly do, but the system doesn't really allow them to do
Exactly.
that. So you have to be prepared as a consumer to go in there and say, this is my plan, this is what I want, and you want to plan that out ahead of time because when you're in labor is not a good time to be arguing and fighting over what you want. So you need to determine these things ahead of time. And if women start putting more demands on their local hospital, that in itself will eventually cause market forces to change. But until market forces force hospitals to change, hospitals aren't going to change for anything for the better. In fact, they'll only get more technical because they get paid better for that. Until the system changes, it's not going to improve. And there is a change coming on, and I don't want to be sounding totally negative. The people are waking up, and women are beginning to ask for these things. And again, the hospital doesn't quite know how to deal with it because they don't only know what they know, and the doctors don't know how to deal with it because they only know what they know. And ultimately, it might be upon the population of women to teach hospitals and doctors what they need to know. And there'll be market forces that will do that. I do believe in the free market economy type thing, and I think that will happen. It won't just happen fast enough. I mean, COVID, we saw an increase of 30% in home birth world. 30% sounds a lot, but when you go from 1% to 1.3%, it's actually not a lot, but it's a start.
So if someone's listening to this and they're thinking, okay, I want to avoid all of that, but I'm not sure what to do now. And just to digress for a second, we met so many. I mean, there weren't that many. I think there were like 13 OBs at the conference, at the Twins and Breech conference. And it was so
Yeah, I mean, five of us were
teaching, basically. Yeah.
lecturers.
Yeah.
Yeah,
So, but I mean, it's refreshing to see this, and it's refreshing to see, I had my own experience, and my birth story will be out there later on a different episode, but things are starting to shift. Um, and I'm more hopeful, and maybe I'll be less hopeful as I get older. But if somebody is really wanting to explore all the options, so they've explored their hospital options, maybe they've gone to a birth center, whether it's connected to a hospital or not. Maybe they're considering a home birth. You and Blyss do, is it a workshop or a webinar about for people who are considering home birth? Can you tell me about that a little bit?
yeah. Briefly, I'll try not
It's
to
okay.
monologue on this one. Yeah, I'm sorry. Yeah, every other month or so, depending on attendance, we have a webinar called "Bringing the Home Birth Hesitant on Board," which is not designed to coerce anybody. It's designed for some woman who may want a home birth, but her partner or her mother or her sister or somebody else is really fearful of that. And so we want them to bring them on with them. And we meet for an hour and a half. I think it's an hour and a half. And we give a little talk. We're actually putting together a PowerPoint presentation for the first 25 minutes of it so that we have it more standardized. And then the last 45 minutes or so will be Q&A where people can just a Zoom meeting and they can just raise their hand and ask a question about, and the questions are usually like, what if this happens? What if that happens? What do you do? Bleeding is one of the big questions. Emergency C-sections, and what do you do? And we explain to them, again, why I talked about earlier, why those things don't necessarily happen at home with the same frequency, and how we are capable at home of taking care of a lot of the things that the hospital seems to dramatize too much, and media tend to dramatize too much. And there is no guarantee, no matter where you give birth, that you're going to have the outcome that you want. But I will tell you, for most women who choose home birth, they're going to be more likely to have the outcome they want than if they go to the hospital. And that is a fact. And people can deny it or people can challenge it. That's fine. But you know, just because it's the truth doesn't make it untenable. It's the
What's
truth.
that baseball quote from that
Um,
movie you say, if they're not a good hitter? I'm not a sports person necessarily.
oh yeah, yeah. No, it's from
Yeah.
Moneyball. It's a. They're sitting around the table and they're talking about this hitter in the minors, and the scouts are saying he's a good hitter. And Brad Pitt, who plays Billy Bean, says, "Well, if he's such a good hitter, how come he doesn't hit good?"
Yep.
And if the hospital is such a great thing, how come it's not so great? And how come that we've gone? Look at the statistics. Look what we've done. Look at outcomes over the last 50 years. And you can't say that the hospital is doing a good job. I laugh sometimes because these people have no self-awareness. I once did a virtual lecture with I didn't do it. I was a attendee, and a guy named Charles Norwich, who was the head of a program. I think he's in the East Coast someplace. And he said something like, he said that nature is a lousy obstetrician. And he was being cute. He thought he was being funny, that obstetricians, you know, that nature is a lousy obstetrician. And I'm laughing to myself, thinking, thank God nature's a lousy obstetrician, because obstetricians suck. And nature does it much better. But he doesn't
Yeah.
get that. He thinks that obstetricians are better than nature, and doesn't bother to look at where obstetricians have taken us over the last 100 years. We are not better off than we were 50 years ago. We might be better off than we were 100 years ago. Certainly medical advancements have done great things, and certainly for things like twin transfusion syndrome or other complications. I mean, newborn intensive care units and maternal fetal medicine doctors have done some great things. Problem is the system encourages them to overtest and overdo things, and leads to all kinds of interventions that are unnecessary, and all kinds of planting of seeds of fear that drive us to bathe our babies for 9 months in anxiety type hormones as opposed to joy and happy hormones, and no concern about what that's doing to developing neurons in your baby and all that stuff when you're putting out stress hormones because you were told at 12 weeks that you have twins, and that the likelihood is that one will die, or they'll your placentas will give out, or you'll hemorrhage, or one will be growth restricted and you'll need to be induced early, and all these scary things that they tell moms with twins. For example, you might have been told, I don't know, that are just planting seeds of doubt that will only germinate and fester in there, when most of the time that's not true.
So, Dr. Stu,
It's just a difference in
I
philosophy.
would
I'm
love
sorry.
to get into the twins specific talking points. Would you? I think I want to wrap up for this one, just so that I mean, I would love to talk to you for. I mean, we could talk about this for days. I don't also want it to turn into a 3-hour episode, but I would love to have you back to talk about breeches and twins specifically. Is that something that you would be okay
Of
with that, right?
course.
Amazing.
Yeah, Jamie, like I said earlier, the chance I get to talk to any audience, to just give people another point of view, to give them information to think about. Like, I don't ever want to tell a family what to do. Um, I don't think anyone should. I don't think my colleagues in the medical world should either. We want to give people information so that they can make an informed decision. Informed consent doesn't come from the doctor. Information comes from the doctor. Consent comes from the patient. It's been a term that's sort of been bastardized. The doctors give informed consent. No, they don't. They give information, and a lot of times it's very skewed. So I just want women to have the best experience possible, and for some that is going to be a hospital birth, because for whatever reason they feel better doing that. But they ought to be aware of what they're getting into. They shouldn't go in with their eyes wide shut. They need to go in with their eyes wide open and understand that these are the things that will likely happen to you when you go to the hospital. So here's what you can try to do to mitigate that or avoid that, as opposed to just surrendering your autonomy to a third party who doesn't necessarily care. It's harsh to say that, but doesn't necessarily care about your autonomy.
Whew, there's a lot there, and
Yeah, I know.
we're going to dedicate a whole episode to autonomy and informed consent and all of that and what that means. So, Dr. Stu, I want to thank you so much for being here today. It's an absolute honor and privilege to be able to sit here and talk to you.
Thanks for having me, Jamie.